Hello, this is Maite Sandrin with Diabetes and Endocrinology, and I'll be talking to you about SGLT2 inhibitors, when to use and when to avoid. First, selecting a patient. Not initial therapy because of cost and coverage mainly, but also other oral agents have a lot more long-term data. Make sure that the patient is on or has tried metformin or has failed metformin due to side effects or whatever is well documented in the chart, along with lifestyle changes. Make sure that is also documented in the chart. If hemoglobin A1C is over 9%, that patient probably already has, or actually not probably, definitely already has a significant glucosuria, and there is a higher risk of GU infections. So not a great patient. They can still benefit from it, but be more careful. If patient is thin, that is unusual for a type 2 patient, and thus you should try to make sure this is not a type 1 patient, since there will be a higher risk of DKA, euglycemic ketoacidosis with the SGLT2 inhibitors. The ideal type 2 diabetic patient is a patient that has known cardiovascular disease, not reaching glycemic goals with metformin and lifestyle changes, or any other therapy, as long as they have tried metformin, or if they have contraindication to metformin, like gastroparesis or definite side effects. Empagliflozin has the most data for the CVD. So you can document that in the chart if the insurance prefers another SGLT2 inhibitors. Sometimes it works, sometimes it doesn't. But I think other SGLT2 inhibitors have some circumstantial data, although not as much as empagliflozin, also known as Jardiance. A patient with declining renal disease, an EGFR less than 90 ml per minute, that would be a good patient for this therapy, especially if they are already on metformin or have tried metformin. A patient with heart failure, because they have volume overload, and SGLT2 inhibitors have been shown to improve patients with heart failure, decrease hospitalizations, for example. Any patient on 2 oral agents who is not a goal, this is a very good third line agent. A patient on metformin and insulin, and this is a patient that increasing insulin therapy, insulin doses may lead to weight gain or hypoglycemia risk. Maybe there's documentation in the chart. Always emphasize that, because the insurance companies might look for that. Emphasize that if increased insulin and the patient had documented hypoglycemia or started to gain weight and they were already obese, that's a great reason to add an SGLT2 inhibitor. And also, in case the insurance prefers the GLP-1 to be tried first, there could be a contraindication to a GLP-1, for example, gastroparesis, or the patient already tried it and they had nausea, or they already have chronic nausea, etc. Any patient with inadequate control with metformin and unwilling to take injectable therapy, or there is a concern about further weight gain or hypoglycemia risk with other therapy. So if these things are well documented, there is a better chance that you will get coverage. Do not use SGLT2 inhibitor if the patient has an established type 1 diabetes. We already know about the euglycemic acidosis, so it's just not worthwhile in these patients. And EGFR less than 30 ml per minute, those are patients that probably won't benefit. There's no documented data that they would benefit, and I would just leave it to nephrology if it's getting close to that. For ertugliflozin, the cutoff is 45 for the EGFR. Any patient that had a prior DKA episode is not going to be a good candidate. Maybe they had certain circumstances that trigger the DKA, and it was only one time, and maybe it was mild DKA, maybe consider, but it's a relative contraindication at the very least, if not absolute. Anyone with urinary bladder problems, Really, anyone that has incontinence issues should not be on this type of medication. In my opinion, any bladder problem, bladder spasms, bladder mass, bladder leakage, any chronic issue that has them at the urologist's office often, please avoid. Any history of frequent urinary tract infections or GU yeast infections. If they have a lot already before starting this class of medications, they're going to have a lot more. So, probably not a good idea. A tendency for yeast infections anywhere, consider not using the SGLT2 inhibitor. Any history of severe perineum infection or GU abscess, I think that's a big red flag that you should not use this class of drugs. Be very careful also if a patient has known osteoporosis, especially if not adequately treated. I'm not sure if it's because of the risk of falls or something directly linked to these medications that can increase osteoporosis risk. A patient has a low normal blood pressure, certainly if they have low blood pressure and symptomatic, definitely not. But if they have low normal blood pressure, the blood pressure may get even lower and they may become symptomatic. So be very careful in that group of patients. Patients that have peripheral vascular disease that has not been fully addressed, such as reperfusion surgery or stent, because there may be a greater risk of foot ulcerations, that as was seen in some studies, and the speculation is that it's because of the lower perfusion to the extremities. Any patient with severe neuropathy, because they can't feel their feet and they may then be at risk of these perfusion problems. Any patient with known history of frequent foot ulcerations, lower extremity infections, or amputations. And any patient, of course, with a history of DKA. These are not, absolute, but, if you can consider another class of drug in these type of patients, then use that other class of drug, and I would be very, very careful. Also be cautious for volume loss issues like chronic diarrhea, people taking high dose diuretics, patients with periodic bouts of vomiting, such as in patients with gastroparesis. These are questions that need to be asked before starting the medication. Sometimes information is hidden in the chart or maybe even absent from the chart. And patients may not always complain about these chronic issues that they've gotten used to. Also, frail elderly patients, because they are more likely to fall. Also, they're more likely to have severe osteoporosis, more often have atypical UTI presentations, especially if they're demented, they may not know how to complain about infections or other issues, and they're more likely to have incontinence. So if it's a frail elderly patient, ask a lot of questions first to make sure they would be a good candidate for the drug. And other reasons, if a patient is already near a goal but has a cardiovascular disease or diabetic kidney disease, you may still consider an SGLT2 inhibitor. You will need more defense of it in the chart. And also, if the patient's taking sulfonylurea, then you may need to reduce the dose. And if they're taking insulin, you may need to reduce the dose because they're already at goal and you're just adding the SGLT2 inhibitor for these other reasons, these complications of diabetes. Then you need to realize that they'll have more hypoglycemias. If a patient is taking a diuretic and they already have low normal blood pressure, you may need to reduce the dose of the diuretic. Okay? And remember to please always educate the patient about the mechanism of action and side effects. Let them know that their urine will have higher amount of sugar. So when they get a urinalysis and it shows high sugar, they're not worried about it. Let them know about the risk of genitourinary infections. Let them know to maintain a very good GU hygiene, avoid excess moisture. Let them know about possible dizziness from lower blood pressure. Tell them to stay well hydrated. Tell them to not wait too long. If they need to use the bathroom to urinate, they should go right away and then dry themselves extremely well and be very clean in their perineal GU area to avoid any complications. And that's all I have today for the SGLT2 inhibitors. If you have any questions, please feel free to email me, mssandrin at srhs.com. Let me say that again, it's msandrin at srhs.com. Or you may call the office, 560-6419. My mobile number is available to anyone who needs it, from the operator or from my office. They'll just give it to you. So any other concerns, let me know. Thank you.